Dr. Mark Montgomery from Portland, Oregon, and I've been using the T-Scan 3 in my practice for a number of years. Initially, I started using the T-Scan as part of an educational program in order to share some of the concepts of occlusion with those who are doing our restorative courses. However, as I started using it more and more in my practice, it became incredibly valuable to every aspect of my care. So in my practice, pretty much all occlusion and all aesthetics run in parallel with the dental treatment that I do in order that my patients can end up with an aesthetic and functional harmony when we finish their care. So whether we're doing small cases or large cases, I always like to use the T-Scan in order to finish those cases to a place that's predictable both functionally and aesthetically. One of the ways that I use T-Scan in my practice is diagnostically. If I can take the initial diagnostic T-Scan movies and correlate the types of patterns that are abnormal with the abnormal occlusal pathology in the patient's mouth, it allows me to develop a course of treatment that will allow us to eventually get the patient where they need to go. Some of these patients need long-term care plans. Not every patient is a bridge case or a rehab case, and not all of these patients can have restorative dentistry done all at one time. By using the T-Scan, I can segment their care and plan their care into phases so that it makes sense for them. An example of phasing their care might be perhaps the first phase of care is periodontal therapy. And the periodontal treatment always is much more successful in an environment of occlusal harmony than it is in occlusal disharmony. Another example of preparing the case for treatment might be in the area of developing the anterior and canine guidance either orthodontically or restoratively with veneers and smile design. If I can understand the disharmony that's present prior to planning the case, then I can build that harmony in as I restore the anterior and canine guidance, and I can develop the types of disclusion and posterior contacts and forces that are appropriate for that patient.